Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Paul Kalra in Portsmouth, England, Professor Robert Mentz in Durham, North Carolina, and Professor Hossein Ardehali in Chicago, Illinois, in order to discuss the role of IV iron in patients with heart failure after publication of the two large phase 3 studies, IRONMAN and HEART-FID. Dear Paul, dear Rob, dear Hossein, it's a privilege for us to host 3 global leaders in the field for a hopefully iconic Iron Summit. Thanks so much for being with us.
Welcome, everybody, to our today's edition, even on behalf of my co-chairs, Markus Seemann and Gunnar Heine, to this, let's say, summit or World Summit meeting on IV iron. Just brief introduction. The background is for our viewers that iron deficiency is common in patients with cardiovascular disease, and even more so when patients with heart failure with reduced ejection fraction. And what we know today is that this state is associated with adverse prognosis. And there's some evidence from randomized controlled trials that iron deficiency may be a therapeutic target and may affect endpoints for patients with heart failure, even if they do not have anemia. And so we're really proud, as Gunnar said already, to have 3 renowned experts on board today. This is Dr. Paul Kalra, the Principal Investigator of IRONMAN, one of the RCTs in the field. He's Professor of Cardiology at Portsmouth Hospitals, the NHS Trust in the UK. We have Dr. Robert Mentz with us, who presented the data of the HEART-FID randomized controlled trials a few weeks ago on the recent ESC Congress. Dr. Mentz is cardiologist and Associate Professor of Medicine, Associate Professor in Population Health Sciences, and member in the Duke Clinical Research Institute in the Department of Medicine of Duke University School of Medicine. And last but not least, we have Dr. Hossein Ardehali with us. He's cardiologist and professor of medicine at Northwestern University Feinberg School of Medicine in Chicago, and he's also director of the Feinberg Cardiovascular and Renal Research Institute Center for Molecular Cardiology. Very warm welcome to all 3 of you. And without further delay, I would ask Dr. Kalra to present some data of the IRONMAN RCT.
Thank you for the kind introduction. So I will go through the IRONMAN trial, just ending up on the updated European Society for Cardiology guidelines that were presented at the same time that, or similar time that Rob was presenting HEART-FID. These are my conflicts of interest. I think the background's been articulated. So pre-IRONMAN, we know that iron deficiency that has been defined by a ferritin of less than 100, or if it's between 100 to 299, a TSAT of less than 20%, is common around about a third to a half of all patients with heart failure and associated with adverse symptoms and prognosis. Several studies, including FAIR-HF and CONFIRM, showed that intravenous ferric carboxymaltose improves quality of life and exercise capacity at least out to 6 to 12 months. And then in the AFFIRM-AHF trial, suggested that there was a reduction in rehospitalizations, given that the patients were recruited just pre-discharge from a decompensation out to 12 months. But the longer-term efficacy, and I think very importantly, safety of intravenous iron in heart failure remained uncertain. So IRONMAN was an investigator-initiated trial. It was event-driven, and we asked patients to consent to electronic health records that permitted us to identify hospitalizations and deaths that we then alerted the local investigators to, who would assess them in usual and report them in usual fashion, such that if we lost track of patients, we would still be able to find events. And that turned out to be hugely important to us, given that our trial had a significant appearance of its duration running through COVID. We used a different iron, intravenous ferric dirysomaltose, And it was a prospective randomized open label but blinded endpoint adjudication. And it's important to note that all hospitalizations and all deaths were adjudicated independently. It was funded by the British Heart Foundation. Pharmacosmos, the manufacturer of this drug, provided the drug and some additional funds. I'll highlight a few of the key inclusion and exclusion criteria. So the ejection fraction less than or equal to 45% might seem odd in 2023, given the way we classify heart failure according to ejection fraction. But the trial was designed really back in 2015-16, and this was before those current criteria were brought in. So heart failure with reduced ejection fraction and soon patients with mildly reduced ejection fraction. Something that I'm sure we'll discuss at the end is what about the definition of iron deficiency? We debated about just having TSAT, but in the end we included TSAT less than 20, ferritin less than 100. And then we wanted a higher risk population, as one does typically for outcome trials, current hospitalization or hospitalization for heart failure within 6 months, or if neither of those, an elevated natriuretic peptide. We could recruit patients to a ferritin of 400, but not above. We felt cardiologists wouldn't feel comfortable giving IV iron with a higher ferritin at that time point, EGFR down to 15. And we capped the higher hemoglobin at 13 for women, 14 for men, given that iron deficiency is less common above there, and we didn't want lots of screen failures. This is the trial schematic. You can see that we tried to give high dose total body replenishment of intravenous iron in a single infusion, and the dosing was according to the patient's weight and hemoglobin, and that was up to 2,000 milligrams per infusion. Patients were randomized 1-to-1, seen at 4 weeks, 4 months, and 4 monthly thereafter. And if they were in the intravenous iron arm, they were redosed if either ferritin was less than 100 or TSAT was less than 25%, but not if the ferritin was 400, over 400. Primary endpoint, pretty standard for historical heart failure trials, recurrent heart failure hospitalizations, and cardiovascular death. Given that we were influenced by COVID, we found that patient recruitment effectively stopped for significant periods after early 2020. And there was significant periods of time in the UK where patients for research were not permitted to attend hospitals for research visits. So particularly during, for example, the first lockdown that came into play at the end of March 2020. And this is different to a tablet trial. So you can post tablets to patients when there are challenges like a pandemic. For the intravenous iron arm in particular, we needed to be seeing people, reassessing for recurrent iron deficiency, and if present, redosing. Of course, that really fell to pieces during the periods of COVID. So according to both FDA and EMA guidance, we did a COVID sensitivity analysis, which is exactly the same statistics, but this cohort, including patients randomized up to the start of the first UK lockdown, which turned out to be 93% of our cohort. And we tracked the data to September 2020, given that in our clinical experience, once a patient's iron replete in heart failure, it's uncommon to need redosing in the next 6 months. And there's a post-hoc sensitivity analysis that I'll mention that was requested by one of our reviewers. Median age 74, which is higher than most studies in trials in heart failure, so not as high as what we see in clinical practice, but we've still got a quarter of the patients who are almost octogenarians or higher. And you can see that 2/3 of the patients hadn't had a hospitalization for heart failure. Median hemoglobin of 12.1, a TSAT of 15, and a median ferritin of approximately 50. 70 centers, and in contrast to the previous studies, we had a median follow-up of just over 2.5 years. We did find that, primarily driven by COVID, that as patient visits went on, so as you went out beyond a year follow-up, fewer patients attended those visits in person. So it was about 2/3 of patients, even at 12 months, who should have been coming back to clinic, came back. So 1/3 of patients then, and that drifted over time. This was an intention to treat analysis. And so the 2% of patients that never received intravenous iron in that arm are still included in the analysis. The majority of our patients had 1 or 2 infusions. In the usual care arm, despite the protocol stipulating you shouldn't receive intravenous iron, 1 in 6 or 17% of patients had intravenous iron, but they remain in the usual care arm. This is the primary outcome. And what you can see is the rate per 100 patient years in usual care, 27.5, with an absolute difference of approximately 5 here with in ferric derisomaltose, you see it being 22.4. Rate ratio of 0.82, so an 18% reduction with FDI, but p-value of 0.07, so not meeting the 0.05 or below criteria typically that we look towards. When we look at the COVID sensitivity analysis, that's in the center column here, we see that in this 93% of patients, the rate ratio is lower, so 0.76. The p-value is now the right side of 0.05. These are very similar to the, in terms of the absolute point, the magnitude of potential benefit with the rate ratio, very similar to a firm AHF and a very similar story with COVID. And we see numerically fewer heart failure hospitalizations, CV death, and 22% nominally statistically significant reduction in CV death or CV hospitalization. On the right-hand side is this group of patients data censored at 1 year to compare to a firm HF, which was a purely all patients censored at 1 year. And we see within that year, it's a 34% reduction in the primary endpoint. I think something important when we're speaking to patients and in shared decision-making is knowledge about the safety and the risks of a potential treatment. I think this is very important. So concerns have been raised about potential infection risks with intravenous iron. We saw no excess risks of hospitalization or death due to infection with FDI, which was a pre-specified safety endpoint, and reminding you that all deaths and all in hospitalizations were blindly adjudicated. This fits with the pivotal data in dialysis patients. There were no excess serious adverse events in any organ class, according to the MEDRA classification. Interestingly, there were 60% fewer COVID hospitalizations with FDI than usual care. Perhaps we might come back to that later. Subsequent meta-analysis involving IRONMAN, AFFIRM, Ponikoski, and an independent patient meta-analysis of smaller studies by Stefan Anker, so just under 3,500 patients. We published this, and you can see when we look at these data, that primary endpoint, a 25% reduction in the risk, p-value of less than 0.01. So the final 2 slides, these are the ESC guidelines published approximately 2 weeks ago, and we see that intravenous iron supplementation is recommended in symptomatic patients, heart failure with reduced and mildly reduced ejection fraction to alleviate heart failure symptoms and improve quality of life. And then intravenous iron with ferric carboxymaltose or ferric derisomaltose in the same groups of patients to reduce the risk of heart failure hospitalization. So thank you very much.
Great. Well, thanks so much for the opportunity to go through the HEART-FID trial, and I'll also share details of a pre-specified pooled FCM analysis where we also included the IRONMAN data at a trial level as well. So these are my disclosures. And just by way of background, as Paul nicely went through, so we know iron deficiency common in patients with HFrEF associated with worse symptoms and adverse prognosis. IV FCM has been shown to improve quality of life and exercise capacity in HFrEF with iron deficiency. In the AFFIRM AHF, as well as the IRONMAN trials, as well as several meta-analyses have suggested potential benefits with IV iron on heart failure hospitalizations without a significant effect on mortality, although some heterogeneity in those findings across trials. Thus, further evidence was needed regarding the effect of FCM and IV iron more broadly on clinical events in patients with HFrEF and iron deficiency. We therefore designed and executed the HEART-FID double-blind, placebo-controlled event-driven randomized trial. This was in patients with chronic HFrEF, ejection fraction 40% or less with iron deficiency, based on the definition on the bottom right of the screen. So ferritin less than 100 or 100 to 300 with a TSAT less than 20. In addition, patients needed to have either a heart failure hospitalization within 12 months or an elevated natriuretic peptide level. We recruited 3,065 patients with 1-to-1 randomization to placebo or FCM. Visits occurred every 3 months and dosing was every 6 months as needed. And as per the dosing regimen on the bottom of the screen, so for instance, patients 50 kilos or greater received 2 doses of 750 milligrams of FCM separated by 7 days. Once iron replete, patients then would transition to placebo and the blinding was maintained a follow-up. The primary endpoint was a hierarchical composite of all-cause mortality and heart failure hospitalizations at 12 months and change in 6-minute walk distance at 6 months. The top secondary endpoint was time to first event of cardiovascular death or heart failure hospitalization over the total duration of follow-up. Given that this was designed in discussions with the FDA with a special protocol assessment, we had a higher threshold for statistical significance for the primary endpoint with p less than 0.01, and for the top secondary endpoint, a specified level of 0.04. The baseline characteristics of this study population: a mean age of 69, approximately a third were women, 11% Black race. In the US, this was 26%. You can see the regional distribution here, a significant proportion, nearly half in North America, a mean EF of about 30%, ischemic etiology and 60%, and a mean GFR of approximately 60% as well. Baseline medication use, notable for 30% ARNI use, 8% SGLT2 inhibitor use, given guideline recommendations evolving over the course of the trial for SGLT2 inhibitors. The study drug dosing and iron indices, median number of injections was 6. The cumulative dose of FCM during year 1, 1,800 milligrams in the FCM group. And at the 6-month visit, 82% in the FCM group received placebo due to adequate iron repletion. IV iron outside the protocol was 7% in the placebo group. On the bottom of the screen, we have the baseline ferritin and TSAT values, as well as values at 6 and 12 months. So mean ferritin in the FCM group was 56 at baseline, and at 6 and 12 months was 289 and 254. The TSAT value in the FCM group was 24%, so higher than some of the earlier programs, including IRONMAN and the AFFIRM AHF, which were around 15%. And at the 6 and 12-month visit, 33 and 31% respectively. The primary hierarchical endpoint of all-cause mortality, total heart failure hospitalizations assessed at 12-month, and then change in 6-minute walk at 6 months. First, for all-cause mortality, in the placebo group, this was 10.3%. There were fewer deaths in the FCM group, 8.6%. This was an absolute risk reduction of 1.7%. Total heart failure hospitalizations, 332 in the placebo group. There were fewer heart failure hospitalizations in the FCM group, 297, with 270 fewer heart failure hospitalization days in total. And then change in 6-minute walk distance in the placebo group, a mean change of 4 meters, a larger increase in 6-minute walk distance in the FCM group of 8 meters for a 4-meter benefit. The p-value by the Wilcoxon-Whitney test was 0.019, so not meeting the pre-specified higher threshold for statistical significance with one pivotal trial, but importantly, now we actually have multiple clinical trials with IV iron, with AFFIRM and IRONMAN, so the totality of evidence is important to take into context here. To help support clinical interpretation of these data, we also presented the win ratio. So when we look at death at 12 months, this represented 18% of the decisions in the analysis. There were 20% more wins with FCM than placebo. When we move to the next level of the hierarchy, hospitalizations for heart failure at 12 months, this also represented 18% of decisions in the analysis. And while there were fewer heart failure hospitalizations and fewer heart failure hospitalization days, when looking at hospitalizations only in those that didn't have a death event, They're actually a similar percentage of wins between the two groups. And moving to the last level of the hierarchy, change in 6-minute walk distance at 6 months, this represented 64% of the decisions, and there were 11% more wins with FCM. So when we report the win ratio, this was 1.10, or 10% more wins with FCM, with 99% confidence intervals just crossing the line of unity. That top secondary endpoint, again, this was an event-driven trial. We were targeting 771 cardiovascular deaths or first heart failure hospitalizations. In the placebo group, 32.2% of patients experiencing an event. There were fewer events in the FCM group. We observed 969 total patients with an event. So our hazard ratio is 0.93 with 96% confidence intervals crossing the line of unity. So a 7% nominal reduction in this endpoint. For time to cardiovascular death, 17.9% of patients with cardiovascular death in the placebo group, fewer cardiovascular deaths in the FCM group. This gave a hazard ratio of 0.86 with 96% confidence intervals as noted. So actually a point estimate similar to what was seen in IRONMAN in terms of cardiovascular death. And then finally, change in 6-minute walk distance. So at that 6-month time point, a mean difference of 4 meters, no significant between group difference at 12 months. However, in a pre-specified responder analysis where we looked at the change in 6-minute walk distance from baseline to 6 and 12 months with specific thresholds of 10 and 20 meters, there's a 24% or greater increase odds of response with FCM, suggesting that certain patient groups may experience a larger treatment benefit. So in summary, before I give a couple quick hypotheses around our observations and then highlight a FCM pooled analysis that we performed. So HEART-FID is the largest study to assess the long-term safety and efficacy of IV iron in HFrEF and iron deficiency, and specifically looking at FCM. It was well powered for the primary and secondary endpoint. We found that FCM appeared safe and resulted in a modest improvement for this hierarchical endpoint, but this did not achieve the pre-specified statistical significance level based on this higher US regulatory threshold. While the observed difference in the primary endpoint were driven by wins and death, the other components contributed to a larger overall proportion of decisions in the analysis. So we feel these data in the totality of evidence with IV FCM from prior studies assessing symptomatic and functional status endpoints, now combined with clinical outcome studies, including IRONMAN with a different IV iron formulation, show the overall safety and clinical benefits of IV iron in HFrEF with iron deficiency. Briefly, hypotheses for the more modest treatment effect observed in HEART-FID. We did have differences in the iron indices, and specifically a higher TSAT value at baseline. Our iron dosing and the timing of repletion also differed from some of the earlier programs, and we did have more heterogeneity in terms of 6-minute walk distance, with regional differences there and other non-iron deficiency related diseases that we hypothesize may have impacted the results. In addition, in contrast to AFFIRM and IRONMAN, which were able to perform more clear pre and post-COVID analyses, the majority of our patients were recruited during the pandemic at a time with marked differences in heart failure hospitalizations, so it becomes more complicated to tease out the impact of the COVID pandemic. Finally, just in the interest of time, I'll hit the high points that in a pre-specified FCM pooled patient-level analysis for an endpoint of total cardiovascular hospitalizations and cardiovascular death, we observed a significant 14% reduction in the rate ratio with FCM, and our other pre-specified co-primary endpoint, total heart failure hospitalizations and cardiovascular death, a nominal 13% reduction. To provide context for additional discussion together, this really was driven by a reduction in CV and heart failure hospitalizations. You can see the relative risk reductions here. And then an important subgroup that it does seem that there is evidence that the lower TSAT group may be the one most likely to benefit. And then we did feel like it was helpful to give a context of pooling at a trial level context with IRONMAN as well, suggesting that the totality of evidence with IV iron, whether censoring, if the 52 weeks or 1 year point, or looking at all of the data. At the 1 year point, a significant reduction, 24% reduction in the CV death and total heart failure hospitalizations, and an 18% reduction when you look at the overall data, not meeting statistical significance in that context. So finally, it has been nicely summarized by Paul as well. Iron deficiency, regardless of anemia status, very common. We know IV iron improves quality of life and exercise capacity. And now we have HEART-FID showing that IV FCM was safe with clinical benefits for patients with heart failure, that some patients may have a larger response and benefit, especially those with a TSAT at the lower end of the spectrum, and important ongoing efforts now to best support implementation for our patients. Thanks so much. I'm looking forward to the discussion.
So thank you, Robert, and thank you, Paul. And now we move over to Hossein.
Thank you, Robert, and thank you, Paul, for that excellent discussion of IRONMAN and HEART-FID study. I'm just going to go over some of the clinical implications of these two studies. These are my disclosures. We know in clinical medicine and basic science medicine, there is always a gap between preclinical and clinical scientists. And I don't think there is a bigger gap in any field in medicine more than what we see here in the field of iron in heart failure. And that's something I want to highlight. I'm not going to talk about the basic science work we have done in our lab, but I just want to briefly talk about how much the field can benefit from what we know about iron biology. I was at the BioIron conference in Durham, Australia last week, and this area was discussed extensively, and how much the communication between the two groups can improve the outcome of some of these studies. I want to also mention that this medicine, the IV drug market, has been increasing significantly. It's $1 billion industry, and it's believed that by the end of this decade, it's going to probably double. So there is a lot of use for this drug, and we need to really make sure that our patients, if our patients really need this drug, or if there are better alternatives for our patients. Over the past few years, we have published a number of papers, both in clinical and also in basic science journals, discussing the use of IV iron in cardiovascular disease. And that's something that I want to summarize today and go over some of the arguments we have made in this area. First of all, AFFIRM heart failure, there is probably the first large study in this area. There were a couple of other smaller studies in the past, but the first one that was large enough was AFFIRM AHF, and it basically looked at IV FCM on hospitalization for heart failure and cardiovascular death. It did not meet its primary endpoint, but there was a reduction in heart failure hospitalization in the IV iron group. And it was more pronounced in patients who were truly iron deficient, meaning that their ferritin was less than 100. And as this has been described before, the correction of anemia wasn't the whole story. There was more into it. Paul just went over the IRONMAN study really nicely, really good study, and it basically, again, didn't meet the primary endpoint, but there was it got really close. There was a median follow-up of 2.7 years, and the secondary outcomes of a reduction in heart failure hospitalization and cardiovascular death was not different. IV FDI was borderline associated with short-term improvements in subjective heart failure symptoms at 4 months, but it didn't meet, there was no difference at 20 months. HEART-FID was presented 2 weeks ago, and Robert went over the data very nicely. I'm not going to go over it, but this is one of the figures in the paper that was published, and there was really no significant difference between the two groups in the primary endpoints. So what are the conclusions from these 3 studies? Again, I know there have been a lot of discussion, but the bottom line is that all 3 studies did not meet their primary endpoints. They got close, but none of them meet their primary endpoints. There is no improvement in cardiovascular mortality. I think we all agree on that, and I think it's a class effect. It's not just FCM, it's not just FDI. There is no improvement in cardiovascular mortality. Heart failure hospitalization has been shown to be modestly improved on IRONMAN and AFFIRM. From what I understand, it wasn't improved in HEART-FID. And there is no evidence of improvement in 6-minute walk. There was some evidence for it in HEART-FID, but this didn't reach statistical significance. So there are a couple of things I want to mention here. First of all, does low circulating iron identify cardiomyocyte iron deficiency? The argument I've been hearing in this field is that patients who have iron deficiency, if they have systemic iron deficiency, that translates into iron deficiency in cardiomyocytes. The other argument I've been hearing is that if you have iron deficiency, that translates to iron deficiency in a skeletal muscle. So these patients are very dependent on their movement of their skeletal muscle, and if there is less, mitochondrial function in their skeletal muscle, they cannot really move much, and that's why they become symptomatic. But the bottom line is that relying on circulating iron indices for intracellular iron levels in cardiomyocytes and other cardiovascular related cell types is not actually correct. We have evidence in our lab that if you make mice iron deficient, it's extremely hard to make their cardiomyocytes iron deficient. It's just, that doesn't correlate well. And probably the best way to assess myocardial iron deficiency is to look at myocardial transferrin receptor 1 and decrease myocardial ferritin. But that's not possible. For that, you have to do myocardial biopsy. But there are, a lot of people right now that are trying to translate what we see in the heart or in a cancer cell and find biomarkers in the bloodstream that can translate, that can detect those deficiencies in cardiomyocytes or, in cancer. So hopefully in the future, the technology will be there to identify iron deficiency in cardiomyocytes or in a skeletal muscle. Also, the other thing I want to mention is that the guideline-directed medical therapy was not probably optimized in these studies. We know that in IRONMAN, GDMT was low, and only 3% were on SGLT2 inhibitors, and only 8% in HEART-FID. And there appears to be a synergistic or maybe antagonist effect between GDMT and intravenous iron. We know that SGLT2 inhibitors increase hematocrit and erythropoiesis, but they also reduce ferritin and T-sat saturation. And that's probably due to inflammation-mediated changes in iron homeostasis. While I'm on this topic, I also want to mention that patients with heart failure, it has been shown that their iron indices are lower. And that could be because of the effect of, being in heart failure, in acute heart failure, their iron indices can be lower as a result of the possible, inflammatory, mild inflammatory condition that comes with it. And the definition of iron deficiency is something that is a major problem, and we really need to come up with a good criteria for iron deficiency. I know all of us, Paul, Robert, and I, we all agree that we don't have good criteria, and the criteria we are using are based on the criteria that is used by renal doctors, and Paul is a nephrologist and is familiar with that, and we have adopted that and brought that into the field of heart failure. These two graphs come from a paper that we published with Piotr Ponikowski's group. And as you can see, in the levels of hepcidin and the levels of ferritin do not really change with the degree of heart failure. And this is not always, there is not an increase in hepcidin. In fact, if anything, hepcidin actually goes down as heart failure gets worse. And this is different from what you see in other chronic inflammatory conditions like cancer, that you see that the hepcidin goes up significantly. So the fact that hepcidin doesn't go up, it's suggestive that maybe it's not, related, it's not one of those, it's not related to, or, patients do not have truly iron deficiency. Now, I'm not going to go over this in a lot of detail, but there is a lot of evidence that patients who have low iron and have low hemoglobin, they're at lower risk of cardiovascular mortality. And we also know if you correct for everything, blood donors actually have lower incidence of cardiovascular disease. So donating blood, which is something I used to do a lot until my ferritin went down to 11 and I started getting restless leg syndrome, it appears to be, a protective effect for cardiovascular disease. And I want to remind everyone the FDA label for IV iron basically says that you give it to patients who are intolerant of oral iron and have unsatisfactory response to oral iron, and patients who are on, who have chronic kidney disease. So giving patients with heart failure IV iron is an off-label use of the drug, and the FDA hasn't approved that. The argument that oral iron doesn't work is based on the studies from Iron Out Heart Failure that peak VO2 did not change in both in placebo versus PO patients who receive PO iron. But patients in the lower quartiles of the baseline serum hepcidin, they showed more pronounced increment in TSAT. And also, please remember, there is no evidence that IV iron increases peak VO2. The studies that were, I think it was confirmed heart failure that claimed that's the case, but that's not true. And so there is really no clear evidence that PO iron or oral iron does not work in patients with heart failure. We don't have that. And I want to remind everybody who is listening to this webinar, PO iron or oral iron has not been studied against IV iron. All of these studies, they used IV iron against placebo. The control arm didn't have oral iron. And there are very good oral iron drugs that are coming on the market. That's the physiological way of absorbing iron. It goes into the digestive tract. It binds to transferrin. It's not like you're loading the vasculature with a large load of iron in the bloodstream. And there is a study called IVOFER heart failure that is going to compare IV FCM versus oral sucrosomal iron, which appears to be better absorbed. TAC trials actually looked at chelators. These are divalent chelators. And the TAC trial showed that there is a significant reduction in cardiovascular events. And this was studied, this was sponsored by the NIH. When TAC trials came, the result of TAC trial came out, people didn't believe it because it was so, there was so much reduction in cardiovascular events, especially in patients who had diabetes and patients who had left anterior descending coronary artery disease. So the NIH is sponsoring TAC2 to confirm these trials. And again, so there is evidence out there that actually, if you use chelators, it may show benefit in patients with cardiovascular disease. So whether or not giving more iron or giving a chelator is beneficial is still out there. The question is out there, and we don't have evidence for it. And also, I know that all of these studies have shown safety, a good safety profile for IV iron, but I want to remind you that there is still some concern about increased incidence of cancer, especially with FCM. Osteomalacia is an issue that wasn't observed in patients in the HEART-FID trial, but we are seeing these patients with osteomalacia due to an increase in FGF23. This paper was published 2 years ago in the JAMA Network Open, and it showed that IV iron is associated with an increase in the risk of infection. So there is, and this is based on looking at the systematic review and meta-analysis of several studies. So I want to end with some of the, I think, myths about IV iron in heart failure. There are reports that heart failure is systemic inflammatory condition. For those of us who do, basic science, we know that there is significant inflammation in the heart in heart failure. We know macrophages, T cells, and B cells are involved, but whether or not there is systemic inflammation, there is really not clear evidence. And as I showed you earlier, hepcidin actually goes down. If there was a systemic inflammation, you would expect hepcidin, as the degree of heart failure increases, hepcidin would go up. There's also this myth that IV iron increases PVO2. That's not correct. That's because in one of the studies, 2 patients died in the placebo group, and they were given a PVO2 of 0. Pure iron, it is believed, does not increase iron levels in patients with heart failure. I don't think we can make that conclusion. Iron out was not done, in a way that patients, not every patient needed iron in those groups. IV iron has been shown to improve outcomes in patients with heart failure. There is some evidence for it, but again, the studies have not shown any improvement in primary endpoints. FDA label doesn't allow giving IV iron to patients with heart failure without a trial of PO iron. Cardiac cells, it is believed to become iron deficient in systemic iron deficiency, and that hasn't been shown. Giving IV iron causes an increase in myocardial iron levels. That I'm not sure that's correct based on what we do in mice. I don't know if that's true. Whether or not IV iron is safe therapy, so far the studies have suggested that it may be safe, but there are also studies that suggest that infection may be increased, and there are some studies that suggest that cancer may be increased. And then we talked about the infection, and heart failure guidelines identify patients with ID in heart failure. That's something that we need better criteria for identification of ID. And ID is comorbidity or risk factor for heart failure. Thus, every heart failure patient with ID should be treated with IV iron. And I'm sure all of us agree that's a wrong statement. Not every patient with heart failure should be given IV iron. So those are all my slides. And again, thank you for a wonderful discussion. Looking forward for discussing this in more detail.
Thank you, Professor Ardehali. Very, very strong arguments from the basic and translational sides. Professor Mentz and Kalra, how would you respond to that?
I'm pretty happy to go first. A couple of important things to correct. One, I'm not a nephrologist. That might be my brother. So maybe that's just an example of some of the facts not being quite correct in that presentation. But I agree, actually. I think there is a big disconnect between basic science and clinicians. And I think that's because the clinicians are seeing the patients. And as such, we see the symptomatology that patients have, the exercise limitation. And I think those of us that are managing patients with heart failure, based upon the data and our experience of managing patients, have seen the improvement in well-being of how patients feel. And we can come on to debate hospitalizations and cardiovascular deaths. But first and foremost, when you speak to a patient and hear what they want from an intervention, they want to feel better. They want to be able to live their life. They want to remain independent, simple things. And I think that's very important. It's nice if it reduction in cardiovascular death, but I don't think that's the be all and end all. So I would say that. Interesting, we do a lot of work, and you'll know that my colleagues in Oxford with the basic scientists run by Hal Draxsmith, we do a lot of work. So we are clinically working. I don't agree that GDMT was low in IRONMAN. I think we couldn't have got people on SGLT2 inhibitors, given that 95% of our patients were recruited prior to DAPA-HF presenting. So you can't predict the future and give people treatments that weren't available at the time. But I do agree that we need to look into the interaction between SGLT2 inhibitors and iron metabolism and heart failure in more detail, because there is a definite lot of interest there. I think that heart failure is it's a multi-system problem, and I think that one of the myths that was raised there about the myocardial iron deficit being the primary problem. I'm not sure that we're saying that. I think we need more data looking at that, and there are studies going forward looking about mitochondrial in vivo function within the heart. But it's a multi-system problem. Skeletal muscle issues is a major contribution to the problems with patients. So there are lots of few things there. I was interesting that the Claytor study, whilst you're mentioning that, I just read the editorial briefly to that. That's worth a read to people. In 2013, the JAMA the criticism of the trial, it really is worth a read, but I won't go into that in any more detail. I think a big problem is how we define iron deficiency. And we, at the moment in 2023, need readily available clinical parameters to look at iron deficiency. There may be better ways in the future. I think the TSAT of less than 20% is something that is more compelling to me. We know in patients that with cardiovascular disease, that seems to correlate very well with bone marrow iron deficiency. I'm not saying that's myocardial iron deficiency. And that's something that I think is really important. I do agree that not all patients with heart failure need to be considered for intravenous iron. Not all patients. I think our current definitions definitely need refining. I think the overall data on hospitalization is important. The patients don't like hospitalization. They really don't like hospitalization. I think the data don't suggest any current evidence for a reduction in all-cause mortality or cardiovascular death. This is heart failure. We've got other data from Pivotal. I know this is high-dose iron versus lower-dose iron, but I think we have safety issues, safety signals there, and improvements in outcome. But probably over to Rob.
I just mentioned one thing. Sorry to interrupt, but going back to what Paul was saying, I'm a cardiologist myself. I see patients, and I agree that patients want to feel better. I don't care if it is a 24-year-old woman who is iron deficient, or if it is a 70-year-old guy who has heart failure. They want to feel better if they're iron deficient, and their iron should be repleted. The problem in this field is that we skip oral iron and we jump into IV iron, and we have no evidence that oral iron does not work in these patients. Anybody with iron deficiency should have their iron should have their iron deficiency corrected. I don't think anybody argues against that. It's just the fact that we have jumped from oral iron to IV iron in this field without accurate criteria to identify patients with iron deficiency is the point that I'm making. Go ahead, Robert. Sorry.
Yeah, thank you. So I tend to agree, I think, with Paul's comments, maybe just to underscore a couple of them. So one around oral iron. So having been the coordinating center for Iron Out, I think it was a well-executed trial with a formulation of oral iron that is commonly used, and it was shown to not improve exercise capacity, or with one hypothesis as to why, related to not actually enhancing iron stores or ability to utilize. So with that specific therapy, we do not have evidence that oral iron works, at least as defined in that trial. And there are certainly other formulations that are being developed and evaluated. So we await those data. But I would say, as a practicing heart failure cardiologist, I agree with Paul, where it's an exciting time for quad therapy in HFrEF. So it's a lot of medications these patients are taking that improve quality of life and clinical outcomes. But still, many of these patients not only are at high risk, but have really poor functional status and quality of life with quad therapy. And we know how common iron deficiency is. So I'm a strong advocate that with the evolving data that we have in this field, realizing, as you note, the complexity of how best to define iron deficiency, whether that should be ferritin agnostic and just focus on TSAT, but thus far, using the parameters as noted and as used in many of these trials, I feel somewhat comfortable identifying iron deficiency and then using IV iron, whether in the hospitalized setting or the outpatient setting, to help patients feel better, function better, and with some suggestions, not only that it's safe, but that may improve clinical outcomes. So talking to our patients, I think Paul hit the nail on the head, the idea of, I'm not adding another pill. It's pretty easy to give IV infusion in clinic or in the hospital to potentially even improve outcomes. I think, yes, there are cost implications that we need to take into account and value statements around that. But I think that this does offer an important tool in our toolkit to help our patients.
What I
tool
liked
in our
about
toolkit to help our
Hossein is this
patients.
is really good science, simply to list what we do not know, where's the absence of evidence. Is it from a wider perspective fair to say, okay, looking at all these studies, we see a positive signal, but maybe a subfraction of patients will profit a lot. And cardiovascular medicine has been criticized to be far away from precision medicine. So will the field move towards biomarkers or what else to identify these patients? Are you aware of that?
I mean, I think you're right, but I think that, you know, precision medicine isn't just the challenges with the precision medicine isn't just restricted to cardiovascular disease. I think this is across the board, isn't it? That we see, you know, we give drugs out in cardiovascular disease that are unlikely to benefit all patients. You know, an ACE inhibitor post myocardial infarction, there will be groups that will benefit more. The same will happen. There's a tiny bit of evidence in renal disease for some benefits, I think, on some treatment. You know, we have got a challenge here, and I think the current definitions have limitations. I really do. But I also, whilst I think there will be patients that may that oral iron could change your iron metabolism on after a long period of time. These patients, firstly, are at risk for a substantial period of time. They're high-risk individuals, and the risk of adverse events is high. And secondly, there is a real challenge persuading patients to take more and more medications. I really do think that's important. We haven't published the data, but in IRONMAN, the results in IRONMAN are, despite 1 in 6 people getting IV iron in usual care, but actually in the first year, 40% of patients are taking oral iron as well in the usual care arm. So the results are despite that.
Yeah, I mean, we know from nephrology that oral iron, there's a problem with hepcidin, and 50% of the heart failure patients have a chronic kidney disease. So again, it's association, but maybe we need more data on that. But are you aware now about this pressing question? Because Milton Peck is always reviewing it, and we see this SGLT2 inhibitor, is it beneficial or disadvantages? Will there be definitive studies about this question?
So certainly in HEART-FID, we had 8% baseline use with additional drop-in over the trial. So certainly we will explore it in that trial, given the limitations of the sample size. I do think we need to be careful about extrapolating hypotheses and mechanisms and leading to delayed or ineffective implementation of therapies that we think are helping our patients. So yes, we'll explore this further. I would hope, but I'm not sure whether there will be definitive large trials looking at concomitant IV iron and SGLT2. Some of those may be real world evidence, albeit with the caveats and limitations of that work. But I understand the hypotheses and mechanisms that Milton and others purport, but I think we do need to be measured in our interpretation and in use of that until we have empirical evidence.
Right, but I think one statement that I made, a point that I made, and I think is worth mentioning again: patients who are in acute heart failure, their iron deficit may go. I mean, this has been shown, and that doesn't mean they're iron deficient. So that's something that should be taken in consideration. If you get these patients and put them on, maximal therapy, and then bring them back a month later, they're probably going to, their iron are probably going to be improved. And that has been shown there is evidence for that. So we got to be careful identifying these patients in the acute setting, and they may not really be truly iron deficient. Can I make one additional point? I think we all agree, I've been practicing cardiology for 20 years. I've never seen a patient with iron deficiency who gets heart failure. I think we all agree that iron deficiency doesn't cause heart failure unless the patient has severe anemia, and the anemia causes high output heart failure. So I think we all agree that iron deficiency is not a cause of heart failure, but it may exacerbate the symptoms of heart failure if the patient is iron deficient, which makes perfect sense. I mean, we learned that in medical school, if your patient is iron deficient, you have to correct the iron deficiency. I don't think any of us argue against that. I think there are two problems in this field, and I really want to emphasize those two problems. One is to identify patients who are who are truly iron deficient, and their iron indices are not low because of being in acute heart failure. And number two, is there evidence that IV iron is better than oral iron? And I agree that some of these patients, they may be really, their iron is too low, that you have to give them IV iron acutely to improve their iron. But the majority of these patients are probably going to be fine if you give them oral iron. And the problem in this field has been that all of the studies have looked at IV iron against placebo. And oral iron that has been used for decades, and it has been used for millions of years by mammals to get iron into our body, has not been used in the oral or in the control group. That's an area that needs more research.
We would love to continue this debate for hours, but we are aware of your time. So thanks so much to the three of you. We are very grateful that you attended this academic debate, and we are particularly grateful for the open discussion, which really allows our colleagues to better understand, on the one hand side, the ever-growing evidence for IV iron, and on the other hand, the remaining limits of evidence. And surely we're looking forward to learning results from the last large phase 3 trial on IV iron, FAIR-HF2 from Germany, and surely also for trials on oral iron supplementation. Hopefully, we may meet again after the presentation and continue this debate. And finally, we are very grateful to the three of you for all the underlying research from you, both the basic research and surely the large clinical trials, particularly in challenging times as during the pandemic. So thanks for being with us and looking forward to hearing more from you. Thank you.
Thank you.